Good morning, good afternoon, and thank you for joining us for today's VIA VitaFlow in association with you webinar. My name is Michelle Harrington. I'm a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We are excited to bring you this educational activity and introduce our speaker. Today's topic is tackling nutrition in female teens with inherited metabolic diseases of protein metabolism, part one. Next slide, please. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note that questions will be addressed during and after the presentation. Please submit text questions into the Q&A pane at any time during the program. You can access a PDF of the slides in the chat. I will be posting that shortly. 1.25 CPEUs are available for U.S. dietitians after listening to this program and completing the required knowledge assessment at the end. That will appear at about 1:55. In the past, we have had some people who were not able to complete the knowledge assessment. You will get an email, and it'll have my email address. Please just reach out. When technology works, it works great, but we certainly understand. So now I have the pleasure of introducing today's speaker. Liz Tulin is a senior metabolic dietitian at Washington University in St. Louis, Missouri. Prior to entering Metabolics in 2010, she was a pediatric dietitian in Norfolk, Virginia, working in oncology and critical care. In her current practice, Liz follows patients with inborn errors of metabolism from birth through adulthood. In addition to diet management, Liz educates training fellows, genetic counselors, and registered dietitians. Liz is an active member of the Genetics Advisory Board for the state of Missouri, serving as a dietitian representative for newborn screening and the state of Missouri Metabolic Formula Program. With that, I would like to turn it over to Liz.
Thank you. Thanks, Michelle. Thank you to VitaFlow and Michelle for bringing this topic up and suggesting that we create an educational session for dietitians about it. So first of all, I have no financial disclosures. As Michelle said, this is a paid presentation. These are all of my own thoughts and views, but I don't have any other disclosures. Today, what we're going to focus on, we have some objectives. And as we started talking initially, Michelle and I thought we have too much to talk about for one, so we have split this into a two-part. But today we're going to focus on identifying three common nutrition management issues in our female adolescents with an IMD of protein metabolism. So we're talking specifically about them. We're going to present some strategies to improve teen self-efficacy with regard to meal planning and diet adherence. And along the way, we're going to be recognizing challenges of living with an IMD of protein metabolism in adolescence. We're going to touch on nutrition management principles for pregnancy within an IMD, and the bulk of pregnancy management will be in our part two series. And we hope to have some fun discussion at the end. So please submit your questions in the chat along the way, and we'll get going. So first of all, what is unique about teenagers and their health concerns? I feel like we tend to, in the clinical realm, have a hard time sort of distinguishing. There is childhood. We pay so much attention on infancy in our management, and it gets to adolescence, and we really tend to focus just on getting them through to adulthood. But really, when we look at adolescence, it's a period of development that starts at puberty and it ends in adulthood. It's a big part of the lifespan. The World Health Organization defines adolescence as 10 to 19 years. They refer to youth in research studies as age 15 to 24 years. But really, this is a developmental period that is rapid, physiological, sexual, neurological, and behavioral changes in this time span. During normal puberty, we see that teenagers are particularly sensitive to external factors, such as stress, and that may impact brain development. And there is an increased incidence of mental health disorders in adolescents compared to children. So we see in this time period of rapid change, rapid growth, we would assume, and also we can see in research, that adequate nutrition is critical for achieving full growth potential. During normal puberty, we have height and body weight increase, and in that time frame, children will have gained 50% of their adult body weight during adolescence. So this is the highest rate of growth second to infancy. And I've always known that, but when I was kind of pulling together this information for this presentation, it really reminded me that this is a critical time period for nutrition in these patients. And then what we're also seeing that's unique to sort of now is we're seeing concerns for undernutrition in patients where they have poor diet quality, and then overnutrition where we're seeing obesity and overweight. And what's unique to this time frame, I think, compared to when I started as a dietitian, is we're seeing really both. We're seeing a lot of kids who are experiencing obesity, they're experiencing overweight, but they're also undernourished because their diet quality is pretty poor in a lot of cases. Okay, so what changes from childhood? What are these things that we're seeing in our teens, specifically female teens? So they obviously have a big growth spurt. We have an increased need for amino acids for building muscle fibers. And so protein intake increases for both males and females. We see an increased calcium and vitamin D needs. Males generally reach their peak bone mass later than females. It's usually in their late teens to early 20s. Females often achieve their peak bone mass by around the age of 18. So males continue to build bone density until their early to mid 20s. Females do not. The increase in bone mass during adolescence is much more gradual in males, which is why they have that prolonged time period. It's very rapid in females in their early to mid-teen years. So it's critical for us to really address these changes in that time period. We also see an appetite increase. For some people, this means that they have an increased caloric demand. We need to keep up with this increased caloric demand. For some people, this appetite increase, if it's paired with a sedentary lifestyle, can lead to obesity and overweight. And then also, if you have some adolescents who are extremely active, maybe they're in sports, or they have a really on the other end of the spectrum. And if they do have poor intake, if their decreased total intake is below the BMR, then we can see growth stunting, we can see a delay in puberty, menstrual abnormalities in girls, and then that also can interfere with their bone mass accumulations later. So this is a general overview. Where can you see all the nitty-gritty details and numbers? Of course, this is in Appendix K of the DRI. I did not cut and paste the tables in here because that would have been too much to see on these slides. But if you look at them, look at the full table and look at the changes between the ages of 9 to what changes between 9 and maybe 15, you'll see every nutrient column has changes. So the needs are varying across it's not just macronutrients, it's also micronutrients. Okay. So now that we see these adolescents, we know they have a lot of nutrient needs that are changing in this time of their life. They also have a lot of internal and external influences that are different than childhood. So what are we seeing? We're seeing peer influences, parental modeling, food availability, food preferences, cost, convenience, of course, cultural beliefs, mass media, also social media, and then we look at body image. So when we look at all of these different influences, I like to look at, this is just our general teenage population in the world, in the US, but this study was referring to the developed world. that it's look at this under a lens of what our people with protein IMDs are dealing with on top of that. So peer influences and parental modeling have a totally different meaning when you're on a protein restricted diet. Same thing with food availability when you have a need for specialty low protein foods or medical formulas that cost a lot of money, right? Or maybe aren't available in your home because you don't have insurance coverage. We also look at convenience and then the influence of social media. I haven't seen this as much in my practice, but I'm wondering if you guys are seeing sort of social media influences on teen choices about their food and formula. If people are desiring, for example, to have more clean eating, or if they're falling prey to some wellness this sort of influencers about wanting to do supplements and wanting to do, that sort of thing. We're not seeing this as much, but I think it might be coming. So I'm interested about people's experiences. And one of the things that just made me feel like we're not doing so shabby. It's not just our patients with IMDs. It's all teenagers. According to the dietary guidelines, the difference between what we're recommending and what they're actually doing is greater in the ages of 14 to 18 years than any other group. So that is a little bit reassuring to me as a dietitian. No wonder they're the hardest for us to work with, in my opinion. Can be very difficult because you feel like sometimes you're saying the same thing over and over again. And that's just part of this age group. So, Michelle, I think we're ready for our first question.
Okay.
Yeah, do you want me to go and read it?
Please.
Okay. So, what influences on food behaviors are you seeing the most in your clinic? And we kind of divided it up into external, so that would be peers, parents, social media, not medical. Sorry, my typo. Internal food preferences, cultural beliefs, for example, availability, so cost of products, access to food in the home, or convenience. So, if you want to
Hmm.
take a minute here, if you want to vote.
Yes, people are answering quickly, Liz. We'll give it a few
Great. I'm going to
seconds.
take a sip of water.
Please do. Okay, we almost have 75% or 76% participated. So
Okay.
I'm going to close the poll and we'll share the results. Okay, Liz, can you see the results?
I can, yes.
Okay,
Can everybody see them or you want me to?
yes.
So first up, yeah, we have external. We have over half with one. That is kind of what I would expect, what I'm seeing. So more from their peers, their parents, and social media versus internal with their food preferences. But convenience and access are they're still a really important part because that's what people are seeing here. So that's really fascinating. All right,
Okay.
awesome. Okay. Great job. Thanks, everybody. Okay, so let's look at more specifically if, let's see, to my next one. Here we go. So what about these teens with a protein IMD? So as I said before, we're looking at these same considerations that we were looking at as teenagers before, right? They have the same nutrient changes that are happening. We're pairing this with a prescribed metabolic diet, low protein restriction of low protein and foods. We're adding formula and or medications. And we're also approaching this from potential comorbidities from having a condition. So for example, if you're working with people with PKU, they have high Phe levels, they may have higher levels of anxiety, they may have some executive function deficits. If you're working with urea cycle disorder patients, they also may have some executive function deficits. And we're really approaching managing and coordinating a complex diet from that standpoint with all of the other changes that are happening in adolescence. So specifically, we're looking at this rapid growth period. This requires more frequent diet and medication adjustments. So as I said earlier, between childhood and adulthood, these teens will gain 50% of their adult weight in this time period. I think historically, I started this position, I've been here 15 years, and I think most clinics operate this way. Correct me if I'm wrong, but where we tend to see our infants a lot more frequently. And then as time goes on, we see people in clinic less and less frequently. And the longer I've been doing this, I really think we need to flip that around. And really, the adolescents and adults need us to see them more frequently. And this in particular here is so that we can make more diet and medication adjustments based on weight gain alone, growth alone, even if their Phe levels are good, or even if their labs are looking good. Really just staying on top of things is really what I would recommend. We also have adolescents that are seeking autonomy. And again, they're having increased influence of their peers, which leads to some other constraints that we're seeing. So we're seeing irregular eating. They're skipping meals, they're snacking, they're grazing, they're on the go. I feel like a lot of teens are extremely busy. They are booked and blessed from 8 a.m. to 8 p.m. So they look at me like, when am I supposed to do this management that you're talking about? I've got all of these things that I'm dealing with: school, parents, friends, sports, music, whatever. And it's a lot. And then plus you add in even a little bit of time to socialize, where they want to eat out with their friends. And what we're seeing overall, because of all of these things, there is an inadequate intake of vitamins and minerals, specifically in this nutrient survey, in this study that I've referenced on the slide. It was dramatically more pronounced in females that they had the inadequate intakes of vitamins and minerals. And so, this is something that we really have to remember when we're meeting with these patients. So let's go on next. So this list of challenges come from a study that Dr. Burton and a group of PKU experts came together and identified this. So these are specific to PKU, but they do apply to our other protein IMDs. So challenges of teens needing to fit in and be accepted. There's anger that results from not accepting their metabolic condition or not wanting to have their metabolic condition. There's some feeling of guilt when they're not adhering to our plans. And there's feeling of shame surrounding that. Again, the risk for maternal PKU. There's some low confidence with these teens that we're seeing. There's concerns about the long-term impacts, sort of like, what am I doing to myself? There are PKU-associated mental health and neurocognitive issues. And then lastly, we do see some disordered eating. So, specifically when we're talking about PKU, the majority of these teens do not want to be treated differently than their non-PKU peers. But there is a reality that there are specific challenges that they face on top of the ones that they just face by being an adolescent. And so I've been asked a lot by parents over the years, and other healthcare providers too, like, can you tell a difference when the patient is being non-adherent? And the reality is, you guys might be shaking your head, yes. In extreme cases, probably, but I think that specifically with PKU, it's very hard to discern what's a high Phe level and what is a hormone-filled teenager. I think about it. I live with two teenagers who do not have PKU, and if they did, I would be constantly asking them to check a Phe level because it is life. They still rage yell. They still don't want to be doing what their mom is telling them to do. So that's particularly difficult. There is also a lot of good research about the feeling of guilt and shame in adults with PKU. I didn't see any studies about teenagers, but I found it really interesting that some adults who have PKU have shame about having the disorder. There's shame about treatment of the disorder or management of the disorder. They don't want to have a different diet than their friends. They don't want to be taking formula. They don't want to be taking medication. But then there's also shame and guilt when you know you should be doing better. This is what they're telling me. They know they should be doing better, they understand that cognitively, but they can't do it or they're not doing it. And so there's some guilt and shame surrounding that. And they're not always open about it. So I found this adult study to be really interesting that the adults were so open about it. And they sort of felt like they couldn't talk to people about it, particularly their healthcare providers, because they were letting them down by not following the plans that the healthcare providers were laying out for them. Um, and then on that topic too, there are frustrations people experience about, um, I know that in our clinic we happen to be pretty lucky that we can get fee levels back pretty readily available because we have a lab in house. But when I'm working with people who do local labs, a lot of times I guide them and I say, you know what, if you're just feeling off, go get a fee level. Let's use that as a guide point, as a checkpoint. But if they don't get the level back for 2 weeks, that doesn't really help them identify what was going on in that moment. So they could be really frustrated about a delay in results versus what that moment that we were talking about. And also some frustrations about, I feel like I'm doing everything right and my fee level is still high. Or I had a urea cycle disorder patient that she was like, I feel like I'm doing everything right and I still feel awful. So, that can be extremely frustrating and it can really, it's not very motivating to stay on the management when you're butting up against a wall like that. Regarding disordered eating, there is limited evidence. So we recognize that the evidence is limited, but it is believed to be underdiagnosed and underrecognized in adolescents with PKU because there's really not a good screening for them. So I don't know about you guys, but we don't really screen for it in clinic. In the Delphi approach study from Dr. Burton, they do give an example of some questions that they would suggest you could screen for, but it's not a validated screening questionnaire for PKU. So it's not something that we're using routinely in our clinic. If somebody has something they're doing, that would be great to share because I feel like we don't necessarily even touch on that in some of the visits because we have so many things. So a screening would be really excellent. We recently had somebody who was very, very compliant for many, many years sort of say, I do have disordered eating and was actually not honest with family or friends about binging in a situation in binge eating, hiding the evidence, and then sort of like, I don't know why my level's high. I'm really doing everything I can. But that took a lot of maturity for that person to talk about it in clinic. And it also took a lot of time. So a lot of the teenagers, when they're actively in disordered eating, we may not be aware of that. So that's something to consider. Okay, so another question time. Give us a little bit of a break here. So do you have access to a psychologist in your clinic? Talk about some solutions here. So yes, full-time. Yes, but it's a shared service. So part-time, no, or that's not where I'm working. Not working.
Okay, they're coming in quickly.
Take a second.
Yes.
Good, good.
Yep, I'll give it 1 or 2 more seconds, Liz, and then I'll shut it
Okay,
down.
sure, sure.
Okay, I'm going to close the poll.
What do we have? Oh, resoundingly, no one has a full-time psychologist. And no access to one. So I feel you, 72% of people, because we don't have one here either. Um, and and I think that we really could use access to somebody. So as you'll see kind of in our solutions we're proposing, I think it would be as we can see through all of this evidence, at diet adherence and nutrient adequacy is more than just a dietitian telling you what you need to eat. We all know this, but the evidence is really showing this as well. Slow. Got it. So, strategies to improve teen efficacy. So, I liked the way that this was broken down by the consensus group that really the teens need three main things. They need education, and they need access to mental health workers, psychologists, social workers, and support. That and support from peers, support from non-peers too, that are like their friends, and non, like for example non-PKU peers. They could use those. So for education, we're going to talk a little bit about focusing on the adolescent, not the parents. So we've already done that. Because by the time they're adolescents, we have talked to these parents more and educated these parents more, and now it's time to talk to the adolescent themselves. So specifically, when do we start focusing on educating the adolescent and not the parent? So in our clinic, this is really a case by case basis. We start that transition in middle school for everybody, where we are kind of quizzing them in a fun and positive way. Who makes your formula? Show me how you do it. Who counts the diet? Oh, are you good at math? Then I think you could be adding this protein and you could be tracking it. We kind of do that even starting in middle school. In high school, most of our teen PKU patients are seen by a nurse practitioner in our office who is fabulous with them. She asks the parents to step out of the room. She asks me and the other dietitians to step out of the room and does one-on-one time with them, because she has found that a lot of times, even though these kids have pediatricians, they defer a lot of the difficult conversations to the genetics team, thinking that we're sort of more of a primary care provider. So she talks to them about really everything. Do you have friends? That all of that kind of stuff. Are you sexually active? And if we are doing education together, we'll come back in the room, either alone with the patient or with the parents, and then we do some further education, really tailored to where they are at that time. So education should really include their blood work goals. I can't tell you, I've known people their whole lives and they still can't tell me what their blood work goal should be. I tell them every time, but just keep doing it. Tell them their blood work goals, how these levels really affect their physical, uh, emotional, psychosocial, mental well-being. If you're working with patients who take medications, review their dosing. For urea cycle patients, we want to reiterate to them what to do when they're ill. And then we have a real honest conversation about adherence. So, you hear this question, what's your why? Why do you do things? And that's really what I try to ask them. Like, why are we here? Why are we talking about this? Are we just here because your parents are making you, or because it's part of the routine? Or do you have something that you really want to focus on excelling in? And if we can capture something like that with them, so like if we can talk about baseball or video games or something like that, that we can directly relate to their management, then usually we can get like a little bit of a hook in there, and that's really a great place to start. Let's see next.
Liz, can I interrupt you?
Oh yeah, please.
Anne from Ireland has a question, and because she has it, other people may as well. What
Sure.
age is middle school?
Oh, sorry, Anne.
Yeah.
So middle school's like 10 to 12, 13, 10 to 13, and then high school is starting around around 14, 15. I think that's sorry, my
Yeah,
US.
thank you.
Yeah, absolutely. And really it's Kathy will if a we'll go through this later in a couple more slides, but if it's a female patient and she has started her period, even if she's 9 or 10, she does like to focus on content with the parents in the room when they're that young, about just making sure they understand what is going on. We don't necessarily boot the parents out of the room when they're that young, but if they're starting physiologic changes, if they're experiencing physiologic maturity through those changes, we might start earlier. So it really sort of depends on when they're having that. Um, so yeah, great. I love this. Interrupt me more, Michelle. It's totally fine.
Thank you.
Yeah. So one of the education suggestions from this study was to encourage the adolescent to contact the clinic more. And I'm not going to lie, like when I read this recommendation, I groaned a little bit because I'm like, we don't have time for this. We do not have time to be messaging patients back and forth. But the reality is that these short, frequent contacts can really be more impactful to the patients. And we, in our practice, we're really encouraging everybody to be on the patient portal. We can't email them. They can email us, but we can't email them back, which is very kind of awkward because they're like, we sent you 50 questions and you never responded. And so, but when you think about it, what they're looking for are some more social interactions, cooking classes. So making that effort to get them to come to a cooking class, even though they're terrified, and then reviewing their formula preparation with them, giving them independence to do all of this on their own. I have a lot of patients come in and they're like, "Can I increase my protein?" And I'm like, "How much are you eating now?" And they go, "I don't know." So I'm like, "No, I don't know that even makes sense. If you don't even know how much you're eating, why am I increasing it?" So there is a lot about that where, just monitoring. I use this with them a lot. And I know I sound like their mom to them, I'm sure, but like if you want independence, you have to take control over these steps before you can really have independence to make these choices. Otherwise, you're always just going to be told what to do. And so for those kids that really want that, that might be a little bit of a motivator for them. So specifically to females, so we're seeing the education for female patients, specifically with PKU, should be a progressive. So we're obviously starting early by raising awareness or risks of the high Phe level during pregnancy. And then, as they're aging, advising on, what do we change during pregnancy? What do we do? And always, always encouraging pregnancy should be planned for these women. Pregnancy can be very positive, it can be a great experience, but it needs to be planned. And so, usually, if they are sexually active and they are not on birth control, for us, that's an immediate referral to adolescent medicine. We have a group here that we have educated on maternal PKU. So they are really great at feeling that they can effectively counsel the parents and the teen on options for birth control and versus necessarily, a family practice person that may not really, want to be aggressive with birth control for a sexually active teen who has high uncontrolled Phe levels. So they won't mince words about it here at our adolescent medicine clinic, which is great. And so we do really rely on them. And what age do we start educating females on maternal PKU? There's really not a consensus. But according to Dr. Singh, this is what she puts out. She always says this education needs to be appropriate for their learning style, appropriate for their access to care. They have to accept the management plan and they have to be ready for change. So as you'll see when we do the cases, I just say this for those of you who maybe have not worked with a difficult maternal PKU case yet. If they are not ready for change, that is extremely difficult, and it's not always something you can change. But when we can tailor how we're approaching it based on where they are at. What is their level of development? Where are they at in their cognitive, their emotional, their behavioral maturity? And based on those sort of assessments with your care team, really that's how you make your plan for these difficult situations about what do we do next. Because it's just it's not the same every time, but we'll talk about those specifically in part 2. Told you I'd have some teasers, Michelle. Okay, so then access to a psychologist, and I did throw social work in here because I know some clinics do have social workers available. And obviously, no one has a full-time psychologist on this call, but they can really help these teens identify, understand, and report these challenges. They may not even know that they have these challenges. I was actually telling Michelle earlier, I forgot to mention, I used to work with Dr. Desiree White before she retired, and we worked with a lot of PKU patients, and she always would tell me and hammer into me that she felt all of these self-assessments that we're doing in patients with PKU have to be taken with a grain of salt, because the frontal lobe of the brain, where the high Phe level is damaging, is actually affecting their self-awareness. So how many times have we asked a patient, but do you feel any different when your Phe level is high? No, I don't feel any different. Some people do, but a lot of times they don't. And then you ask somebody that lives with them, are they struggling with XYZ? And they're over there vigorously nodding their head. And our patient's like, no, I have none of these problems. That's part of the condition. That's lack of self-awareness just transfers through. And so that's where a trained psychologist or a trained social worker could really help these patients identify where their struggles are, because they may not be able to identify it themselves. We have seen only in one patient, so I'm not saying this is routine, but for a patient who did have routine therapy for cognitive behavioral therapy with a psychologist, we had a patient who did that as a set frame over Zoom for 8 weeks, and it was specifically for diet and medication management, where they set weekly goals and objectives related to management. They would check back in, and then the psychologist would walk them through behavior changes that were needed to meet the goals that were set by the patient and the dietitian. And if every patient could do this, that would be absolutely amazing. And for this patient, it was quite successful. And we're trying to explore it for more people. But obviously, this is brand new for us. That they could be able to do that by Zoom, and I could see it being a huge benefit for patients. Okay, and then support. So, no shortage of camps and programs available. What is hard is getting people to sign up for them, in my experience, convincing these teens that they need to go to these programs and reduce this social isolation, whether it's perceived or actual. And there is data from these camps that does help short term to improve their metabolic control. And then the other thing that I have encouraged, probably to deaf ears most of the time, is to involve real life friends. They can bring, if they have a close confidant, a close friend, a boyfriend, a girlfriend, somebody that they are spending most of their time with, they could come to clinic. Sometimes I make them practice real life scenarios. Not exactly role play, because I do not like doing that, but we will walk through a scenario of, okay, what do you do if you're on a date and you're ordering from this restaurant? Where are you going to be? Let's pull up this menu in clinic right now, and we're going to go through this so that you're not stressing about what you're going to order. And then also, the study suggests that it could help them avoid indulging, because they're just like overwhelmed. They're like, oh, I'll take that. And then also some risk-taking behaviors that they're prone to do, being teens. Sure. Okay. So specifically with female adherence, in regards to the literature, there's mixed reviews. So when it comes to diet adherence, specifically with PKU, the most significant factor across all studies is age. Blood Phe concentrations get higher as people get older. Gender is much less consistent. There's some studies that say there's no difference in Phe levels between boys and girls. One study said girls had lower Phe levels than boys. And I can just tell you anecdotally, I could see patients manipulating this in the real world. Right. So a lot of female patients that I've worked with that have like a type A persona, they come to clinic, they have their diet records that are meticulously, beautifully written, color coded and glittery. And and they have a perfect Phe level and we see them in 6 months, it's great. But what's really happening in that 6 month period? It could be very different than what they're presenting, because they may be able to be sort of playing to the test, meaning they know they're getting a Phe level drawn. So they're tightening control right before the level. And sometimes you are, asking them questions and they're like, I feel fine, everything's going great. And that may not always be the case. So we do, that kind of harkens back to encouraging the more frequent levels and more frequent follow-up for people. So, uh, okay. So here's some other ideas for strategy. These are all excellent suggestions. I did not make them up. They're part of Dr. Burton's study. I think some of them are not as realistic as others for the dietitian to implement, as much as the entire team. But I do think that we have a role. I love the idea of the digital and innovative education modules. I think as a group of metabolic dietitians, we've really seen that happening with YouTube videos, education models for patients to look at online, that sort of stuff. The biggest thing that we've done in our office is flexibility of the healthcare providers. So I know our dietitians and our healthcare providers have really been flexible with the schedule. One, if we know it's going to be a long visit, we really tell the doctor it's going to be a long visit and you need to have time for that, because they really need to talk about a lot of things. That's why I say we're really lucky. We have a nurse practitioner who really understands that, and she will sit with them. She has this ability to like put her arm on their shoulder and say, how are you? And she like looks them in the eye and they start crying. It's a amazing skill. So to be able to have, and then our role, knowing all of these challenges they're facing, the fact that they're here, that they're talking to us, our role is to really listen to these challenges and not refute them and not combat them, but really say, you're right, this is really hard. And really try to help them reduce the shame that's associated with management. There's a suggestion to help them beyond the health of their IMD, right? So what are your life goals? Like, what are you doing after this? And then to really be regularly screening them for these comorbidities. I could add disordered eating to that list, anxiety, depression, and disordered eating, and then really helping them with this transition to adulthood. Not many 18-year-olds are capable of monitoring their own MyChart and our little patient portal. The day they turn 18, their parents are cut off from it. So then they have to re-sign up, add their parent as a proxy if they want to. Just that little bit, like asking an 18-year-old to make a phone call to a person to set something up, I don't know that a lot of them would do it. It's really hard. So just having some empathy in that and really helping them. If they transition out of your clinic, we follow them forever, so they never leave us. But if helping them identify new providers and assist them with setting up the appointments as well. So, I mean, really just focusing on taking away the stigma. Their parental pressure could be really huge, especially when things start to slip. A lot of parents come in and they're just like, I tell them what to do and they don't do this and that. So really separating them out of that could really be helpful so that they can make small, manageable goals, something that they can achieve, and then frequent follow-up. It feels impossible, but it's actually, I think, what works, what I've seen success with. So when we're talking about formula, what drives their formula choices? So I think you all know this. This is nothing new. They're looking for taste. They want something that tastes good. They want something flexible. They want something available, which I put cost in there. I know they're not purchasing it, but if it's expensive, it might not be in their house. They want something that does not make their breath stink to their friends. They may be considering the volume of the amount they're taking or the frequency of servings. And then I did put their caloric amounts might drive their choices on there as far as feeling full and how active they are if we're adding in maybe more formula for a really active teen, for example. Okay, so that's what I've seen. But what are your teens, specifically female teens, looking for when they are choosing a formula. So we can take a couple minutes. Are they looking at taste, volume? Do they want less calories, more calories? Are they looking at the ingredients? Do they want clean, environmentally friendly packaging, or is it something else?
And this is a multiple choice, so you can pick more than one answer
Oh,
because we thought it was so fascinating.
I think it is.
Yeah. Just give it a little bit more. I don't know if there's a little lag or not, so I'll just wait
Oh,
one or more.
maybe.
Yeah. I just want to make sure everyone gets a chance because this
Sure.
is so interesting. Okay, Liz, I'm going to shut down the poll.
All righty. What do we have here? Oh, yeah, taste. Taste overwhelmingly, volume, less calories, more calories. Some people with the ingredients, environmentally friendly packaging, and then something else. So great, right, right in order there. That's kind of what I've seen in my practice as well. If it doesn't taste good, they're not going to drink it. Well, no matter what the volume is, no matter what the ingredients are. But I do find it interesting that some people are that the teens are looking at the ingredients. I'm starting to see it more in my college age kids and young, I would say 20s somethings, that they're looking at the packaging and they're looking at the ingredients, but maybe that's because I'm in the Midwest. We're a little behind here compared to the rest of the country.
Okay.
So, all right, let's see. All right. So, that's great. We're looking at behavior and we're looking at why teens are choosing the things that they're choosing, but we're a group of dietitians. So, what really are we doing to improve their nutrition? And here's the bulk of it is. So, back to those four things that we talked about on that other slide. The rapid growth. So, they're hitting a growth spurt. So, what do we need to look at? They need increased protein equivalents for specifically for PKU, for tyrosine and we really need to make sure we're talking with the team about maximizing their medications and we're staying on top of doses as they grow. Increased calcium and vitamin D needs. This is something that is making me revisit all of my teens that are into the quick and easy products that are not completely full of micronutrients. And so historically, I've always said, oh, sure, you can take that and pair it with a vitamin. But is that really what they're going to do? Is that really what they are doing? I don't know. Given the data about bone mineralization, I really feel like focusing on that quality of formula when so that there's a full range of micronutrients when able is really good, is really important. And then their appetite increase. So this is where you may consider a high calorie formula depending on their where they are at in their weight. You may consider a GMP product if they're not feeling full enough, if that's appropriate for them. And you may consider mixing and matching. So this is where we really need to be flexible so that these kids are recognizing that they have more appetite, recognizing that they can't just eat whatever they want because they have a restrictive diet. And so, how are we helping them fill the gaps in there? And then also, they are hugely at risk for iron deficiency anemia in teens. I always have thought about it in as the age of 1 being the highest risk, but actually there was some data in some of these studies that iron deficiency anemia is rampant in teens as well, specifically females. So we really need to be screening for that and making sure that their metabolic formulas have plenty of iron, if not, an iron supplement. Okay, so let's touch quickly about pregnancy. I think we'll have some time at the end here, Michelle, because I only have a couple of slides about this, but this is just a segue again into our part 2. But when we're looking at pregnant teens in the world, there are 16 million babies born annually to girls ages 5 to 19 years. And that's 10% of all the births in the world are born to adolescents. And nutrition is critical. It's actually an area of research that needs focus is this competition for nutrients between the mother and the fetus while the mother is actively growing. There's very little research about that. There are studies that show a mom is still able to have linear growth during pregnancy, but only if her nutrition is adequate. And so we can see that, nutrition in pregnant teens is critical because their bodies are not physically ready for pregnancy necessarily. And the teens, as we've seen, they tend to give a low priority to nutrition, despite having enhanced needs for a nutrient owing to their pregnant state. So you can see their choices are not necessarily the greatest for a nutrient dense diet, paired with perhaps still requiring some growth, physical growth. So specifically, what nutrient needs change? So there is an increased metabolic demand. There's an increase of 300 to 500 calories, depending on their BMI at the start of pregnancy. We know there's an increased need for folic acid, an increased need for iron, so not quite double compared to non-pregnant teens. And calcium and vitamin D needs do not change. They're actually the same during pregnancy, but the protein needs, this is for a non-IMD teenager. This is just a standard old regular teenager. The protein needs increase dramatically during pregnancy. And so you can imagine for somebody on a protein restricted diet who gets most of their protein from synthetic formula, that is even more dramatic of an increase. So what are we looking at? Back to our practical management strategies. Increased metabolic demand. In my experience, a higher calorie formula is a must for them. It's very hard for someone with PKU for a woman with PKU to control her Phe level with a low calorie formula in the early days of pregnancy. It's really, really hard. And then I, again, would reiterate that they would need to be looking at what I would call a complete formula, meaning all the macronutrients are there and as complete as possible with the micronutrients, rather than relying on supplements to meet that. You need to balance your medical food intake with your natural protein intake. And then for medication management, it's really important to keep up with doses and work with your medical team to monitor and help with nausea. Morning sickness could require some aggressive medical management. Consider having several formulas available at home. That's what I meant by that. Because what tastes good in the morning one day might not taste good at noon the next time. So I try to have the pregnant women have just a smattering of everything that they could just run through and say, what will I tolerate at this moment? Typically a low volume, high protein equivalent formula, and you balance that with some higher calorie foods can work as well. But we'll go into some much more specific details with our case study. We have a maternal PKU case and a pregnant teen with tyrosinemia that we'll talk about at our next session. So my references are all included on there. And I just want to say thank you before we go to questions. I really appreciate Michelle and VitaFlow having me here.
Oh, Liz, thank you. This was wonderful. We do have some questions. Are you ready?
I'm ready. Okay.
Okay.
Okay, go ahead.
So first question, how do you involve teens in the decision-making process when selecting a formula? And I'm going to keep going. It's a two-part question. And since
Mm-hmm.
taste is the number one driver, do you find taste preference is individualized or are there some patterns?
Oh, that's a really great question. So pre-2020, we sampled formula in clinic. We had a kit. I had like a Tupperware that I would take down to clinic filled with options, because I had found that when I sent samples to the home, they just weren't being used. They were sitting there and they're like,
Mm.
"Oh, no, I never tried that. I'm fine." So I felt like trying them with them and like troubleshooting it with them in clinic was really, really helpful. Now, what we tend to do is send a bunch of samples to their home from the various companies. We may package it together. We may ask a company to send stuff, and then we will hop on a Zoom visit, a Zoom video, and walk them through each of these choices. Here in Missouri, our access to formula is variable. So sometimes we're limited by what their insurance will cover, won't cover, and what our formula program offers and doesn't offer.
Yeah.
If they're in Illinois, they get whatever, they can choose whatever, and we can send whatever to their house. So it's very, that kind of depends on what's available. But we always ask them their opinion first. And I usually present it by saying, this is my choice for you as a dietitian. This checks all of the boxes. But the reality is the best formula for you is the one you're going to drink every
Yeah.
day. So that's kind of how we kind of go through it. And it may not be what my choice is for them,
Yeah.
the one that they like. And then we have to perhaps, if it's an incomplete formula, then we have to, give them supplements of calcium, vitamin D, something like that. Yeah.
What role do peer or social influences play on their choices? So we're still on the formula.
On the formula. I mean, I'm sure people have other suggestions, but what I've seen is, I have some kids that don't want to drink it in front of their peers at all, so they don't
Yeah.
even know. Like I have a couple of patients that actually will just hide it, and so if they're over at a sleepover, they'll tell me they're like, I ran into the closet and I drank it really quickly in the closet.
Oh,
And that's really sad because they just don't even want to tell their friends. And then there's other kids that their parents have created a really open social environment. They've said everybody needs to know what you have so that we can all take care of you. And so, so that's kind of the way to approach it. But it's really up to them about what they feel comfortable sharing with their peers. But a lot of kids will say their friends are like, you know, why are you drinking that? And then they don't know how to explain what PKU is and why they're doing it, or they don't know how to explain what a urea cycle disorder is. So I went to a fifth grade classroom once and presented on PKU because I had a patient that was really being bullied by some kids in our class.
oh,
And so we went in and talked about it, and that just makes it normalizes it, kind of,
yeah.
this is what this is. And isn't this cool that she knows how to look at a plate of food and tell you how much protein is in it? Or isn't this cool? So we've done that before too. Um,
Great.
but it is really hard.
Yeah.
Yeah.
Okay. Liz,
Yeah.
do you have specific stages of counseling for patient education on dietary strategies in their teenage years?
Um, I do not. I'm not that
Okay.
organized. I know those exist. Um,
Yes.
I know they exist and we could find them, but I kind of do it by feel at this point of where they're at. And a lot of times it'll be a session where I'm like, oh, this person's ready for some like
Yeah.
real counseling. And then we set up a real close follow-up afterwards. So we find that while insurance may not pay for a dietitian only visit on telehealth for a patient, Nord will. And so a lot of times if we can do because my university won't allow us to not bill. I would love to just meet with people and not bill them, but
Right.
that's illegal, I guess. So they don't want us to do that. So we can do that and Nord will cover that. And so we'll try to do a little 15-minute check-in, and that kind of keeps them accountable. And we can say, you know what, you talked about this last time. Here's the next step. But I'll be totally honest, I'm not usually walking into the clinic visit prepared with that, but I probably should be.
Is it fair to say though it also would depend on the patient because some females are 13 and they act like they're 20. Some females are
Yep.
13 and they act like they're 10. So variability is also,
Yes.
yeah.
Yeah. And sometimes it's shocking when you go in and you're sort of like, oh, I was prepared for something totally different. And they're way less mature than you thought they would be, or they're masking a little bit about, sometimes the provider will go in, and almost always the provider goes in and they tell them something completely different than what they told me, or they, something like that. And then I'll have to go back in and say, what are we talking about here? Kind of, yeah, get that straight.
Okay. This is from Anonymous. Thank you for
Okay.
sharing your knowledge. How's your experience with MSUD patients?
Oh, yeah. I didn't even mention MSUD. I don't have any experience with pregnant MSUD, which is why I didn't experience that. Teens, I do have experience with that. And it is not that different from urea cycle disorders, I would have to say. So those two I would pair. They struggle with the same things. They really do struggle with um, not wanting to have a condition, especially if they're hospitalized every time they're sick. This starts to become a cycle that's really challenging. They're missing school. They're falling behind. And in my last teen MSUD patient, he got transplanted because it was such a drag
Yeah.
for him to be doing that. So that's, what we were dealing with that. And the transplant went very smoothly in that case. And he was able to go to college and sort of thrive. So they planned it that way, but that's great. I think they fall, honestly, if anything, they fall right in line with all of these challenges with added complications in that they take more medication, their diet is more stringent, and if they don't adhere to it, they can't lie to you if they're not adhering to their diet. The labs do not lie. Their mental state does not lie, so they can't hide that as much when they're not adherent. I think for MSUD.
Huh. Are there any emerging innovations in medical formula design that you believe could improve adherence or quality of life for the teen?
Um, I mean, that might be a better question for VitaFlow. But for me, honestly, the for the teens, I think we have for PKU, we have a huge variety for them. Honestly, we do. I think if anything else, when we look at tyrosinemia, I think we need
Yeah,
some expanded options for tyrosinemia. We don't have the same flavor options or even just choices of a format. So, of low volume, high volume, all of that kind of stuff. We just don't have that flexibility. So the more rare
yeah,
disorders, I think we could use some benefits. But with the
yeah,
advent of GMP, I feel like a lot of my teen patients, a lot of times it's just that they're done taking formula. They just don't want to
yeah.
do it. You know what I mean? And it's not really that it's the specific products. It's just
Hmm.
they're kind of over it.
Yeah. Okay.
So.
Any experience with medical food being mixed with coffee?
Oh yeah, I love that. I mean, I don't know what you got. Iced coffee, not hot coffee. So you don't want to denature the protein. So don't put it in a super hot coffee. But we definitely recommend that. I mean, the recommendation for teenagers for caffeine is something like less than 150 a day, I think. Don't count me on that, but I think it's like they could have I just talked about this with my daughter. She said she can have 2 shots of espresso and still be under the limit for caffeine for the day. So that is a grande
Ah,
drink
I love
at
it.
Starbucks. 2 shots of espresso. But they could do that certainly mixed with some of these flavorless formulas. Powdered options. I think that'd be great. The coffee flavors there's like anything mocha or chocolate. I love
Yeah,
experimenting with that. I think that would be a great option.
nice.
Yeah. Yeah. I
Okay,
love.
Liz, we're going to take one more question.
Okay.
This is from Brittany. Curious about your experiences with patients with homocystinuria. Thank you for your presentation today.
Thank you. Oh, I left off my HCU patients. I forgot about them. Thanks, Brittany. Homocystinuria is interesting in that the two that I work with, that our clinic works with, less frequently me, more the other dietitians now, but they have a higher natural protein intake compared to some of these other restrictions. So they still have to take formula and they still have to take medications, yes. But the amount that they're allowed to eat is a little more broad. So I tend to forget about them as being more protein restricted, but they are definitely ones that need more formula options. I will say that they do not have a lot of great choices. And the choices they have are their bare bones sort of options. But that's because it's a more rare disorder. So I understand that. But that's what I would that's what I think would be the biggest challenge for them, especially as they get into adulthood. I'm
Great.
sure other people have seen that. Yeah.
So,
So
right now I do have the knowledge assessment up, and I'm going to keep it up for a little bit before we shut down the webinar. This is mandatory per CDR to get the CPEUs. It's only 4 questions. We'd also really, really appreciate it if you could take the time to answer the survey. We learn so much from this, and we always love hearing about new topics. But at this time, I just want to say thank you again to Liz. This was an exceptional presentation. I want to say thank you to the audience. It was really great
yes.
hearing what you're seeing. That was fun. We hope that you will join us for part 2 of this 2-part webinar series. It will be same time, June 17th. And this was a build for that presentation. So, as Liz mentioned, this is going to be case studies. And these are being recorded. So, if any of your colleagues missed it and want to see these will be available for watching later. So, again, I just hope everyone has a great day. And thank you, Liz, and we'll see you soon.
Thank you.